Assalamu alaikum. This is one of the important clinical examination that you have to know. It may be one of the stations in your examination. It's about the AV fistula examination. Why the AV fistula examination is an important one? Because most of our dialysis patients, about 95% of our dialysis patients who have chronic hemodialysis should have an AV fistula as a vascular access for their hemodialysis session. Also, the Kiduki guidelines recommend that physical examination of the AV fistula should be performed by a qualified individual on regular basis, at least monthly. Qualified individual may be the doctor in charge or the nurse or the head nurse in the hemodialysis unit. Why to examine the AV fistula? Because the quality of the AV fistula, and you should, if it's functioning well, means that the hemodialysis could be very good for the patient and could have an efficient hemodialysis session. We have to know that the examination includes, like any local examination, inspection, palpation, and auscultation, no percussion here. First, it's an inspection. To start with the inspection, as usual, we have to know two rules. The first rule, an inspection should include the whole extremity, starting from the chest, shoulder, breast, neck and face, and the arm and forearm, and the hand. This is the first rule. The second rule, you should compare both extremities. You should compare both upper limbs with each other. Why? We are going to explain this later. These are the items you should know while you are doing the inspection for your patient. Number one is the site, then signs of inflammation or infection, then two swelling, hematomas and aneurysms, and the swelling of the arm itself and the presence of collateral veins or not. Then you can look for the signs of ischemia and do the arm elevation test. These are the items of inspection. To start with the first one, which is the site. So number one is the site of the vascular axis. We have three sites that the vascular axis can be performed. Where the vascular axis can be performed. Number one, between the radial artery and the cephalic vein. You should know that the AV fistula is a connection that is done between the artery and the vein to create or to cause arterialization of the vein. So you can have a vein with a strong wall, so you can connect the needles of dialysis each session. Why we don't connect to the vein? Because the vein have weak wall, also may cause rupture and inflammation of the vein, so after some session there will be no veins to connect. Why not to connect to the artery directly? The artery is deep structure, it has pain receptors in the wall, so it can cause pain over the session. So here comes the idea to cause arterialization of the vein so we can connect the needles of dialysis. So the first site is the radiocephalic. You can find the scar of this fistula at the distal part of the forearm. The second is between the cephalic or cephalic vein and the brachial artery. You can find the scar of this fistula at the cubital fossa. The next one is between the basilic vein and also the brachial artery. You can find the scar of this operation at the arm at the medial aspect of the arm near the axilla. So for the first one, the radiocephalic, it's a connection between the radial and cephalic. You can find the scar at the distal of the operation at the distal part of the forearm, like this one, the arrow show, and the vein like this. We connect the needles of the dialysis. The two needles are connected to the vein, only the vein. No needles are connected to the fistula itself or to the artery. We just connect to the vein. So this is the scar and this is the vein which is formed after the operation. This is the radiocephalic. Another site is the snuff box. You can see the scar as in the picture. So whenever you find this scar, you know that it's radiocephalic fistula. After this is the brachiocephalic, like what's shown in the picture here. You can see the vein and the scar. The first arrow show the scar of the operation at the cubital fossa, and the second arrow show the vein which is formed after. Then the basilic one, the picture blue show the scar of the operation which is at the medial aspect towards the axilla, and above it there is the vein. This one is an enlarged one. Here this is the scar of the operation, you can see it, and this is the vein where we can connect the needles. So after you can detect the site of the fistula, you can look if there is signs of inflammation or infection or not, like erythema, purulent discharge, ulceration. The first picture here shows there is erythema, also there is ulceration, and there is purulent discharge. The second one shows there is swelling and redness or erythema of the forearm. The third one shows there is ulceration and purulent discharge at the site of the fistula. You can see the yellowish discharge here. After the site and signs of inflammation, now we have to see there is for the swelling hematoma and aneurysm. This is hematoma at the site of the AV fistula. If you find it, you can describe there is a hematoma at the site, usually due to the wrong cannulation technique of the AV fistula. Then this is the aneurysm. The aneurysm is enlarged part of the fistula like this. If you find the aneurysm, you have to see to look if there is thinning of the skin overlying, if it's shiny or not, if there is depigmentation, ulceration, or if there is rapid enlargement of the aneurysm. This means that this aneurysm may rupture at any time and it's risky, so you have to refer to the vascular surgeon. But if there is no signs of impending rupture, we can still use this AV fistula, but with good precautions. These are an example. In picture A you can see the ulceration in picture above the aneurysm. In the other picture you can see there is depigmentation and shining of the skin overlying the AV fistula. After you find the AV fistula, you have to do the arm elevation test. If we see here, this is the AV fistula. It's a connection. There is a connection between the artery, the radial artery, and the cephalic vein at the distal part of the forearm. The artery is the inflow of the AV fistula. What's meant by this? That the blood that comes to the AV fistula comes from the artery. So we call the artery the inflow, which carries the blood to the AV fistula. It's the inflow. And the vein is the outflow. It takes the blood from the fistula towards the heart again. So the artery is the inflow and the vein is the outflow. Usually when the AV fistula, when the patient is lying in supine position, you can see that the AV fistula is elevated above the surface of the skin, like in picture A. When you do the arm elevation test, you raise the arm of the patient above the level of the heart. So like this, you will raise the arm of the patient above the level of the heart. Usually when you raise the arm above the level of the heart, the fistula will collapse or will go down. It will not be swollen like in picture A. This usually occurs because when you raise the arm, this causes more drainage of the AV fistula, more drainage of the blood. So this is what should happen. If the fistula didn't collapse or didn't become flat, this means that there is outflow obstruction. There is obstruction of the vein. So you have to examine by Doppler or Doppler ultrasound to show what is the obstruction site or what is causing obstruction of the vein. After this, you have to look for the next item if there is a swelling of the arm and the presence of collateral veins or not. I told you before that one of the important rules is to compare between both arms. If you look here, you can find that the arm including the AV fistula is much more swollen than the other limb or the other extremity. This usually due to obstruction or stenosis of the central vein draining that arm. Obstruction or stenosis of the central vein draining that arm. Here you can see there is also collateral veins. There is a swelling of the arm with the presence of collateral veins in this arm, including the AV fistula. This usually occurs if there is central venous stenosis. What is meant by central venous stenosis? So what is meant by central venous stenosis? Usually if we know the anatomy of the upper limb, after the cephalic there is the basilic vein and then the axillary and then the subclavian, brachiocephalic and superior vena cava. These are the veins draining the upper limb. If there is obstruction at the level of the brachiocephalic, subclavian or superior vena cava, this means that or this causes swelling of the limb and presence of collateral veins in a trial to drain this upper limb. If the swelling involves only the arm, this is subclavian vein stenosis. If it involves the same side of the chest, breast and or face, this is brachiocephalic. If it involves both sides with the breast and shoulders and chest, this means superior vena cava obstruction. You can find the veins dilated on the chest of the patient. At the end of the inspection, you have to see if there is signs of ischemia or not. Also, in this item, you have to compare both sides. If you look at picture A, you can see there is pallor and cyanosis of the limb, including the AV fistula. If you compare both limbs of the patient, you can find that one shows a cyanosis and pallor, and the other is good, with good blood flow and good perfusion. This means that the arm, including the AV fistula, had an ischemia, and the patient may show pain all over the session. If there is severe pain and there is severe pallor and cyanosis, this fistula may be referred to the vascular surgeon to be closed to and to do another fistula for the patient. Now we have finished the items of the inspection. After the inspection, we will have to know the palpation and auscultation. For the palpation, we have to palpate for the pulse, if there is thrill or not, and to do the augmentation test for the patient. These are items of palpation. First, to palpate the pulse, you have to use your finger. You can palpate the pulse over the AV fistula and the vein using the palmar surface of your finger. Usually, the pulse is soft and compressible over the fistula and the vein. If you find that the pulse is hyperpulsatile, this means that there is obstruction over the vein. There is distal obstruction over the vein. If you find the pulse is weak over the AV fistula or the vein, this means that there is obstruction or stenosis of the artery, which is the inflow of the AV fistula. To palpate for the thrill, you have to use the palm of your hand. You put the palm of the hand over the fistula, and all over the vein you can feel the thrill. This thrill will be felt systolic and diastolic, and it's soft. Usually the thrill is like a vibration. When you put your hand or the palmar surface of the hand over the vein or over the fistula, you can feel this vibration, systolic and diastolic. If you feel it only systolic and strong and localized, this means that there is a stenosis over the vein. And if the thrill is weak or you can't feel it well, this means there is obstruction over the artery, the inflow of the fistula. So for the pulse and the thrill should be soft, continuous, systolic and diastolic, diffuse over the course of the axis, over the whole vein. Even you can feel over the axillary and you can feel over the chest. But if the pulse is low or hypopulsatile, discontinuous, and the thrill is not felt well, this means there is inflow stenosis over the artery taking the blood to this fistula. If you find that the pulse or thrill, the pulse is hyperpulsatile and the thrill is accentuated or strong, this means there is a stenosis in outflow, which is the vein draining the AV fistula. Again, the artery is the inflow and the vein is the outflow. The artery takes the blood to the fistula, so it's the inflow, and the vein takes the blood out of the fistula or drain the fistula, so it's the outflow. After this, we have to do the augmentation test. What is meant by the augmentation test? Again, I'll say that the artery is the inflow of the AV fistula and the vein is the outflow of the AV fistula, draining the AV fistula or taking the blood out of the AV fistula. Usually, the augmentation test is done like this. This is the site of the AV fistula, the connection between the artery, blue, and the vein above. Usually, you put your finger 2 centimeters away from the site of the opening or away from the site of the fistula, and push your finger down till you close the vein, till you close or occlude the vein. When you close the vein, so you closed the outflow or closed the drain of the vein or draining of the AV fistula, and the artery continues to push the blood to the AV fistula. So this will cause the segment between your finger and the fistula, the segment between your finger and the fistula to be hyperpulsatile, and the thrill will be absent after the site where you close by your finger. This is usually or normally what will happen if you do the augmentation test. Again, the augmentation test is to close the vein 2 centimeters away from the site of the AV fistula. So the segment between the AV fistula and your finger will be hyperpulsatile and the thrill will be absent after your finger. If you do this test, the augmentation test, and you find that the segment which should be hyperpulsatile show weak pulse, this means that there is stenosis of the artery, or at the opening of the AV fistula there is infilostenosis. The blood which comes to the AV fistula is low or weak. So the stenosis will be at this site. If you do the test and you find after closure of the vein that the thrill is still present, this means that there are other collaterals which carry the blood to the fistula after the usual opening. So if you close and you still feel thrill after your finger, this means that there is collaterals taking the blood to the vein after this, and this causes inadequacy or insufficient hemodialysis. So after you do the inspection and palpation, we can after this do the auscultation. Usually if you try to auscultate the AV fistula, you will auscultate or hear a bruit which is like the thrill, but this is auscultated by the stethoscope, which is systolic and diastolic low pitched. If you find that this bruit is high pitched and systolic only, this means there is a stenosis over the vein or obstruction over the vein, which causes this sound to be accentuated and systolic only. If you find it weak, this means there is infilostenosis. Finally, you have to auscultate for the heart or cardiac auscultation to detect if there is newly heard murmurs or not. If you find there is newly heard murmur, first you have to close the AV fistula by your hand. If you still hear the murmur, so this is newly formed over the heart and you have to do an echo to find its cause. But if you closed the AV fistula and you find that the murmur disappeared or you can't hear this murmur anymore, this means that it was just a transmitted sound. It was just a transmitted sound from the AV fistula and it was not from the heart. So this table can show the main difference between the infilostenosis over the artery, outflow stenosis over the vein, or if there is central venous stenosis over the subclavian, brachiocephalic or superior vena cava. All over the examination, how can you differentiate between them? It's a summary of the difference between them during each type of examination or each item of examination. You can read it finally. And finally, thank you for your attention.